Alrighty, here we go. David, welcome to the Dialogues.
Yeah, thanks for having me.
No worries. We've done a few of these now, and it's been fun because people are always in a variety of locations. The beauty of technology. So, do you want to just, for the listeners, give us a bit of a background on where you're at the moment?
Yeah, so I'm in Newport Beach, California. Kind of get a little bit glimpse of a palm tree behind me, I think, through the window. But I work as the program director. I'm an adult endocrinologist. I'm working as the program director for a diabetes center called the Mary and Dick Allen Diabetes Center. We're affiliated with Hoag Hospital, which is in Newport Beach.
Nice, very nice. It'd be quite useful actually to hear a little bit about your background. I'm always curious to know about how you got to where you're at. How did you end up becoming an endocrinologist?
Yeah, interesting question. So it was a journey that there are a couple of different things I can point to. So growing up, my mom was diagnosed with type 2 diabetes when I was in junior high. And that was a really impactful experience for me. I remember, my mom was really worked up about it. I didn't really understand. And so we all tried to learn more about diabetes. I actually still have the book I checked out from the library in 95 or whenever this was.
Yeah.
And it's really funny to look back on, by the way. But we would try to bake these horrible tasting sugar-free pies and stuff like that to cheer my mom up, which was probably the exact opposite. But yeah, so that was kind of my initial exposure to diabetes. And then kind of in medical school, so my dad is a physician, and when I kind of, wanted to follow in his footsteps. So in medical school, I would always kind of, my ears would perk up when I would hear diabetes, or it was one of the topics because I knew my mom had type 2 diabetes. But I didn't really see it as my future career. But in internal medicine, so internal medicine is a general specialty that you have to do before you decide to do a subspecialty, and endocrinology is one of those subspecialties. So during my internal medicine residency, I still wasn't sure what I wanted to do. And I did a rotation through endocrinology just because my mom. But once I did it, I really fell in love with the technology and type 1. It was something that was really fascinating to me because I'm always kind of a tech guy, fulfilling Asian stereotypes. So I was really into technology and gadgets and things like that. And so being able to use that in such a way to affect health and improve people's health was really fascinating to me. And the other thing I liked about it is that there's so much of a personal component, right? A lot of times managing type 1 or diabetes in general, it's kind of being, as a doctor, we're more like a coach rather than, it's not so much the medication that I'm prescribing as much as it is teaching people how to live their life and make good decisions and analyze their numbers and stuff like that. So I kind of like that coaching aspect that really resonated with me. And I really like having different age patients. So, a lot of type 1s are younger.
Yeah.
So I like having patients all across the spectrum. So it's been really fun. And that's kind of how I fell in love with it.
So I'm interested in, I guess, the expectations or the perceptions that you had as a student, and with this idea, once endocrinology became kind of the area that you're interested in, versus the realities of today. Are they in line? Are you doing what you thought you'd be doing? Is it even possible to kind of know what you were going to be doing anyway? How does the realities match up versus the perception you had back then?
Yeah, that's a great question. In a weird way, I know this sounds really cheesy, but I feel like it's even more fun and what I would want to have done than I was expecting,
Right.
And to answer that, I guess in my training as a doctor, it's still, a lot of it still seemed kind of like work. And as a tech enthusiastic resident and trainee, I was kind of unique, right? So I was going through my training, when I was in medical school, the iPhone came out.
Yeah.
And so I remember always being the nerd who was interested in technology and stuff. And everyone else was just be a doctor, calm down. But as I've gone more deeper into type 1, and as just as the technology is evolving in type 1 and in healthcare in general, it's just, I think the fact that technology has taken such a prevalent figure, a footprint in healthcare as a whole, I think
Yeah.
is really exciting for me. In a way, it's almost like too much. It's like, I feel like a hipster a little bit when it comes to technology and healthcare. I'm kind of like, oh man, I cared about this before it was cool, you know?
Yeah.
But now it's just exciting because like there's so much cool technology in all avenues of healthcare, and that's really exciting. And then in addition, another way it really surpassed my expectations is like, I think the more I've gotten to know and understand type 1 and helping people with type 1,
Yeah.
it's just been such a pleasure. I think like understanding like the like going beyond the numbers and going into like understanding people's quality of life, and that's where technology can really help. I don't know, just like my interaction and my understanding and my experience with people with type 1 has just been super rewarding, and it's just been really awesome. I'm so happy.
That's awesome to hear. And that's partly how we connected, I suppose, given that my interest and the business that we have with Not Just a Patch, the interest is around CGMs. And certainly for me, as a type 1 diabetic, the CGM technology has been a game changer.
For sure.
Really grateful to have access to these technologies because, quite simply, my HbA1c has come down
Yeah.
considerably. Was what 6.9, now it's 5.9.
Nice.
So like it's made a definite impact. And I tend to think of it a little bit like health informatics, which is an area that I worked in. My undergrad is in as a health information manager, and then I worked in some medical technology areas. And, I think trying to understand health informatics and actually kind of understand the field of informatics can be quite daunting because it's such an ambiguous term, informatics.
Right.
But
Right.
I think for me, one of the ways that when I would try and talk about it with people at work was wearing a CGM. It's like having these micro informatics available that help you make these sort of micro decisions. It's
For
almost
sure.
like the power of health informatics in action, in that I get this information that's immediately available to me, and available to me like so much, it's so much easier to scan my reader than to prick my finger. I used to probably prick my finger 4, 5, 6 times a day, if that. Now I'm scanning, 40 times a day or more. And it's that health information at my fingertips that ultimately is what makes the difference for me.
Totally. And like I that resonates with me 100%. I mean, I always tell people like diabetes is like 10 years ahead of what the general public is like in terms of health technology and, wearables and things like that. So, 10 years ago when Fitbit was first getting popular, everybody was talking about wearable sensors, and CGM, had already been out by like 5 years, for 5 years at that point.
Yeah.
And so in many ways, and I feel like people with type 1 diabetes, they really are like the forerunners of, the quantified self movement and the wearable sensor movement and health technology and digital health. And I think down the road, eventually, as these sensors get better and better, they're going to get smaller and smaller. I think the use cases are going to expand. I wouldn't be surprised if, um, like maybe even potentially something like glucose monitoring to some degree in an Apple Watch, so that athletes and people trying to lose weight are regulating their blood sugar or watching their blood sugar. So yeah, in many ways, it's like type 1s kind of have a glimpse of the future in that regard.
Yeah. I actually read something, I think in the last week or so, about some watch or some wrist technology that is able to give glucose reading. I can't remember who it was or where it originated, but they had some comparisons versus the Libre, and
Yeah, if
it did
you're
show a bit of variation, but it also, I think, is quite promising, right? To think about the capability of that being, on your wrist and giving you information, live almost.
Yeah, it's kind of like the holy grail, like a truly non-invasive continuous glucose monitor. Um, the product, I think I am familiar with the product you're talking about. And I think it made a lot of headlines because I think they made a splash at the recent Consumer Electronics Show.
Yeah.
But I think the problem with a lot of these technologies is that they tend to be, they're not like medical grade, right? Like I don't think they would ever get to the point, or at least not in the next 5 years or 3 to 5 years, where like someone with type 1 diabetes can dose their insulin or use, automated insulin delivery using that.
Yeah.
But maybe it has a role, and maybe it might be accurate enough to do like trend information, right? Like, so for someone that doesn't have diabetes, maybe it's like high sugar, or something like that.
Yeah.
That might reinforce healthy eating or something like that. But I think the accuracy is really challenging. That specific sensor, I believe they were compared to like people without diabetes on the Libre, and the challenge there is like, if you don't have diabetes, your blood sugar varies so narrowly. It's like from 80 to 140 pretty much all the time.
Yeah.
That it's hard to differentiate between a good watch and a bad watch with that narrow of a range of normal.
And we are seeing a number of companies starting to pop up in the lifestyle sort of metabolic space who are using, and I mean, even I think one of the cycling teams that competes in the Tour de France is using using the Libre actually. So we're starting to see a lot of crossover into the mainstream for this technology, and at face value, not as a not wearing a doctor's hat, it makes sense that actually, if you wanted to improve your lifestyle and your diet and your health in general, using a CGM to kind of get information on your blood sugar level is a decent proxy for starting to improve your overall healthcare.
Yeah, no, 100%. And, I think it's just more of a cost and technology issue, and that's getting better and better. And, I think as someone who does not personally have type 1, I've worn it a few times, over the years because I sample it for my patients. And I'm always fascinated by the information that I learn. You just seeing how different foods affect your blood sugar, seeing how exercise affects your blood sugar. I mean, these are all things obviously type 1s are quite familiar with, but it's just so fascinating for anybody to learn from their body in that regard. Now, the numbers aren't as dramatic in the swings, but it's still very meaningful and helpful.
And do you think that those businesses, just sort of to deviate for a second, those businesses that are starting to creep into, try and help people manage weight and healthcare using CGMs, like, do you have a perspective on that as a doctor? And I mean, I'm sure you're aware of it. What's the thinking in the medical field of this type of? It's almost a bit of it's starting to cross over, right? And I think it kind of goes back to this concept of wearables and healthcare, and even back to like the regulatory space. The lines are getting blurred between people who can coach and help with healthcare or lifestyle versus a doctor. What's the discussion on the medical side of these types of businesses? Is it coming up?
I think so. Yeah, it's interesting. There's a few ways to look at it. I think from a business perspective, like putting on my fake investor hat, I think it's really smart that these companies are doing that, because I think it's only going to become more and more prevalent, right? So these companies are basically establishing their name, they're establishing data sets, they're kind of iterating on the apps or whatever experience that they're layering on top of the CGMs. So that maybe, what if in 3 years Apple does create, a CGM enabled watch? Then that would be a perfect integration or partner to be bought or something like that. So I think from a business sense, it makes perfect sense for these companies. And there's definitely, health and wellness is a huge market. I think putting on my physician hat, there's a little bit of skepticism in the sense that, like, is it like, what I tell people a lot of times when they ask me about this is like, sure, it's helpful to understand to some degree, when I'm eating more carbs and when a person without diabetes is eating more carbs and when they're eating less carbs. But it's tough to really know what normal looks like, and like, what exactly are they trying to achieve? What exactly are they identifying as problems? Because those patterns, those data sets just don't exist.
Yeah.
But it's important to establish those data sets, and these companies are building that. But it's hard to know what, like, is it truly is it truly beneficial to have a blood sugar of 110 versus 125 in someone without diabetes? Like, what does normal look like? What are you trying to achieve? I think that's where it becomes very gray, and that's where you worry that there might be a little bit of snake oil mixed in, or at least just nothing, not evidence-based medical care. So it's a ideal health and wellness product. I guess the question is whether it's a medical product. I would say it's definitely more health and wellness at this point.
Yeah, and look, I think that we're never really going to be able to replace the role of or the training that, say, an endocrinologist has, because your understanding of the mechanisms and what's underlying a lot of the information and a lot of the experiences that a patients are having, like the training that you have is really important in that context to be able to advise. And I think that's probably one area that's going to be lacking in any of the coaching or lifestyle businesses that are popping up using these types of mechanisms. In going back down that path, and just to kind of go back, I suppose, to the beginning of around your training, I'm curious about what you learned at medical school about diabetes, the endocrinology field, versus kind of what you know now. And sort of, I'm always fascinated because I think, medicine and science is always moving forward, always learning new things. There's always big changes. Can you speak to any of the things that have significantly changed in what you knew then versus what you know now as an endocrinologist?
Yeah, I think it has changed a lot. And unfortunately, I think this is why a lot of type 1s, especially, you know, might not be satisfied with their healthcare experiences, both in your country and in mine. I think the amount of exposure we have to type 1 diabetes in our medical schools, at least when I was training, is not very high. And I think there's such a large focus on type 2 diabetes that the type 1 kind of gets drowned out a little bit, and there's not a huge emphasis. So obviously, one thing that's changed a lot, I'm sure, is the technology. And so now, in medical school, there might be some discussion of continuous glucose monitors, but, in my training, when I was training, there was very little, at least at the medical school level. And I think just kind of understanding I think as type 1, as someone with type 1, that there's a lot of frustration sometimes when you get clumped in with type 2, right? There's so many differences between type 1 and type 2 diabetes that it's a disservice to kind of bundle them together. But I think, unfortunately, even I would guess that even in medical training now, they're often bundled together. And at most there might be a table differentiating the two that we look at on a page of our textbook.
Yeah.
So I think it's definitely undersold. So but I was really blessed because I did my training at UC San Diego for endocrinology, and one of my main mentors, his name's Steve Edelman. He's an endocrinologist, kind of a world famous guy, but he has type 1. And one of my co-fellows had type 1. And so I think both of them are very passionate about conveying the differences, and how type 1 is more of a lifestyle, what am I trying to say? It's such a different disease. And I think training under Steve Edelman and kind of getting to know more type 1s as I've gotten more immersed in this world, I have so much respect and admiration for the fact that it's a totally different disease process. And I think that's something that even now, unfortunately, too many doctors and even some endocrinologists, I think, don't fully appreciate that subtlety.
Yeah, look, and I think as a type 1, it's not necessarily something that frustrates me personally, but certainly when I listen to the community, it's one of those things that you've even got t-shirts and mugs that are dedicated to this concept of the silly questions that you get asked as a type 1. Right. And that's certainly one of them. And it's actually interesting to hear. I don't think I was fully aware of the opportunity that exists in medicine to improve in the training around type 1. In saying that, what I guess there are similarities, aren't there, in type 1 and type 2? They're both metabolic. Are they both? Would you say they're both metabolic? Well, they're both glucose related. I mean, maybe speak to the similarities first of all of type 1 and type 2.
Yeah, I think the similarity, like I would agree with that correction you made. So they're both diseases of glucose regulation, right? So the end result is similar in the sense that, someone with type 1 and type 2 are having glucose control issues, right?
Yeah.
That unless they do the right things or take the right medications, their blood sugars will be poorly controlled. And the end result of poor sugar control, whether it's through type 1 or type 2, is similar, right? You can have
Yeah.
kidney complications, blindness, nerve pain, amputations, things like that. So the end result, or at least the outcome, the measurable outcome, which is blood sugar and complications, is similar. The underlying mechanism is what's often different, because type 1 is an insulin production problem, right? Because your immune system has attacked your pancreas, you no longer make insulin. Whereas with type 2, it's more of an insulin resistance problem, meaning your body can make enough insulin, at least initially, but the problem is your body doesn't respond as well to that insulin. And so other similarities between the two is that so insulin can definitely, insulin is a staple in type 1 management, as you know. In type 2, it's kind of the last of the medications that we use. So a lot of type 2s will be on insulin as well. So in that sense, it can appear similar. Another thing that you may or may not be familiar with is, even though there are medications that are FDA approved for type 2 diabetes, some of them actually have some benefit for type 1s as well. So even sometimes there are some pills or injection medications that are not insulin that are technically approved only for type 2 diabetes that might have some clinical benefit for type 1s off label. So so some of the medications, there's a lot of overlap.
Is metformin one of those?
Sorry, what was that?
Is metformin one of those?
So metformin is, I would not include it in that, because so there's another thing that I guess we didn't mention, is that just because you have type 1 doesn't mean you can't have type 2, right? So you can actually have both, unfortunately.
I did not know that.
What was that?
I did not know that.
Yeah. So, the stereotype for type 2, which is partially true, but partially not, is that someone who's kind of overweight, not as active, that can worsen insulin resistance, which is the underlying process for type 2 diabetes. And that same process can happen to someone with type 1. So say, you were diagnosed at the age of 5, your autoimmune system, destroyed your ability to make insulin. So you're a true type 1.
Yeah.
But maybe you also have a family history of type 2. Maybe you put on weight in your 30s or 40s, start being less active, and you might find that the amount of insulin you need in a day, maybe it used to be 30 units that you needed, but you might find that now you're needing 60, 70 units to get the same end result. In that situation, you're starting to develop insulin resistance. And if that's the case, something like metformin would help. But if you are a true type 1, metformin probably would not help. But if you have features of type 2 layered on type 1, then it can definitely be of help.
It's really interesting. This is a bit of a deviation, but I was listening to something recently where they're talking about, or looking at metformin as being a wonder drug, and having applications for things like just general longevity, like actually helping people live longer and being like this kind of potentially wonder drug in that space.
Yeah, every once in a while, you'll see headlines pop up that like some Silicon Valley CEO is taking metformin or something like that. And it is true that some of these studies that look at large scale data sets seem to suggest that there might be a reduced incidence of cancer, certain types of cancers. Some studies have shown, maybe reduced incidence of dementia, and, even independent of the blood sugar effect. So there is some signal to that suspicion, but there hasn't been like a randomized controlled trial designed to confirm that or deny that. But it is definitely something of interest. And, when I meet patients who are really reluctant to take metformin, sometimes I'll kind of throw that out there to help make them feel a little bit better about starting to take it.
Really interesting. Speaking of randomized controlled trials,
Mhm.
an area that I'm interested in, I think our listeners will be interested in, is whether or not, or what kind of data exists, or what plans there are that you might be aware of to generate some data comparing CGMs.
Yeah, that's a good question. I didn't prepare ahead of time for this question, so there might be data that I'm not aware of. But it is true that most of the time, most of the studies I'm aware of are like, somewhat sponsored by these device manufacturers, right? So Dexcom sponsoring a Dexcom study, Abbott sponsoring a Libre study. So most often they're being compared against finger sticking. Um, as far as I can tell, I can't think of a head-to-head comparing CGMs in terms of outcomes, but that, what I can think of at the top of my head is not an exhaustive literature review. But so I haven't seen that, but that is interesting. But I guess part of the question is then, who would pay for that study?
Yeah.
So it's hard to design something like that. But I do think down the road, as it becomes more prevalent, I think especially at least with automated insulin delivery, that might be worth looking into. But the very nature of clinical trials and sponsored clinical trials is often companies are a little bit reluctant or hesitant to do head-to-head comparisons against their competitors. A lot of times they're doing head-to-head comparisons to like older medications or something like that. And so, yeah.
Yeah, and that stands true, I think, regardless of the field we're in, right? Like, even if you were to look at, I don't know, transplant medicine, for example, and you were to compare like the older sort of, was it called cyclosporin, which was
Yeah.
used for kidney transplant, like even the newer transplant drugs, like, what is it, like a Myfortic or something like that. They they even tend to compare more so against, the older drugs. I think maybe slightly moving ahead there, but that tends to be true in medicine, right? So yeah, I mean, look, I think the summary here is just that it'd be nice to start to see that data where we can get a sense of what CGM, or how CGMs compare. My general feeling is actually that there'd be probably very little difference in probably the larger outcomes. And these are just, like pure hypotheses, but that the actual, say, HbA1c impact or the time in range impact, my guess is they'd probably be quite similar. But I think that the real interesting parts would be in the quality of life or the quality of experience in using. So it's those kind of patient reported experience type measures that would be
Mhm.
the ones that probably are the most relevant. Like, how often did they fall off, or, what getting the alerts, all the, just the general interaction from patient to device would be the area that I think would probably be of particular interest.
Yeah, I mean, I think that differentiation is especially true for these algorithms and the automated insulin delivery systems. Um, yeah, because I think that's going to be, obviously control and time and range on a CGM is going to get better and better. But I think it's going to reach, going from 50% time and range to 60% time and range is a lot easier than going from 80% time and range to 90% time and range.
Yeah, exactly.
And so once a lot of people, once these algorithms are good enough to keep most people above the 70s and some in the 80s, I think that's where, quality of life, like you say, is going to be such a big component. And you're right. I think that's going to be, that's what really matters to people, right? Because I think even now, sometimes when I look at CGM tracings, I'll tell a patient, I'm like, hey, this is awesome. Your time in range is like 85%. Congratulations. And then they tell me like, oh, but I'm eating all the time because I'm about to go low. But I don't see that because they end up eating to prevent it from going low.
Totally.
So their CGM looks great, or at least their time in range looks great, but I don't know that they're having to munch, 6 times a day. So those are the types of things that we have to, get a better sense of assessing. And I 100% agree.
So in terms of your day-to-day practice and your day-to-day treatment of type 1 diabetics, what are the kind of current issues or topics or experiences that you and the patients are having? Like, what are the areas of focus right now?
Yeah, good question. So not sure when this is going to air exactly, but obviously, in California, COVID is a big deal. In the US, our vaccines just got approved about a month ago, I think. And so I think that's a very frequent topic of conversation is my patients are kind of asking when they can get the vaccine, if they're going to be prioritized. Right now, for reference, at this point of the recording, it's primarily healthcare providers, like frontline workers and elderly adults, at least where I live, who have access.
Yeah.
So I think a lot of my type 1s are very, anxious about trying to get on the vaccine. They some of them are asking me if they should get it or not. So that's definitely top of mind for sure. In terms of innovation, one of the exciting things that I do is, speaking of continuous glucose monitoring, I do prescribe and do these procedures for a different continuous glucose monitor called the Eversense.
Yeah.
It's an implantable continuous glucose monitor that is inserted under the skin. And so that's something that is really popular in certain portions of the population. Like especially, for example, patients that have like rashes to the adhesive from their Libre or their Dexcom, if they're having problems with it staying on too long. Obviously, you have a solution for that as well. But some people just want a different type of paradigm for a continuous glucose monitor, and the Eversense is a good option. And then I think the last thing that's probably top of mind for my patients is I think there's just a lot of growing enthusiasm and interest for automated insulin delivery and better automated pumps.
Yeah.
So in the US right now, Tandem is kind of the only true, what we call a hybrid closed loop pump. They have something called Control IQ technology, which automatically adjusts the basal rate of the pumps.
Mm-hmm.
It does a little bit of auto correction boluses, but you still have to bolus for your meals. But that's been a real game changer for my patients. But it's still a tubed pump like the Medtronic. So I have a lot of patients that are really excited about like tubeless options for that. So like an Omnipod with some automation that should be hopefully getting FDA approval later this year. So I think those are kind of the three main topics I would say: automated insulin delivery, advances in CGM like the Eversense and such, and COVID vaccinations and COVID related topics.
So I want to go into, well, two questions. I'm keen to kind of understand a bit more about Eversense.
Yeah.
I'm also keen to, once you kind of go down that path, I'd like to come back and kind of go into one or two patient stories, particularly around the pump, and kind of get some sense of like specific patient experiences and where you've seen whether it's improvements or not. But just give us a little bit more information about Eversense. I think most, maybe that's my assumption is most diabetics wearing a CGM would have some awareness about Eversense, but maybe it's because I spend a lot of time in and around CGM world. Maybe my view there is a bit skewed. But certainly, like, I've seen it. It's fascinating, I think, the concept of it. Do you want to speak to, and I think maybe like using patient experiences or use cases that you've got,
For sure.
where especially if you've seen someone like on a Dexcom or on a Libre where they've gone across to Eversense, I think that kind of experience would be fascinating to understand.
For sure. So real quick, it's an implantable sensor. It's about the size of a big, maybe like a extra long Tic Tac, perhaps. So this is what it looks like on my camera. But basically, so this type of Tic Tac looking thing would get inserted in the upper arm. So it is like a minor surgical procedure. We make a tiny incision, we slide it in. You don't need stitches or anything like that. and it can be worn for 90 days or kept in there for 90 days at the moment. In Europe, they already have a 180-day product. And in the US, hopefully by mid-year or end of year, we should have a 180-day version as well. It's important to note that you still have to wear a transmitter on top. So you still have to wear something like this over the sensor to get a signal.
Yeah.
So at that point, you might say, okay, if you still have to wear something over the skin, why would I want to do this over a Dexcom or or a Libre? But the big difference is because there's nothing actually penetrating the skin, you can take it off and put it back on whenever you like. So for example, one of my patients, she played water polo. And in the water, I guess it gets pretty dirty and pretty violent. And so she was saying that when she would wear her Dexcom, people would grab it and pull it off of her skin. But now she can just pop it off during a match. And then after her match, she puts it back on and, no worse for wear. Obviously, you don't get numbers during your match, but at least for those 2 hours or whatever, you can just pop it off and put it back on. Similarly, I have patients who, want to go to the beach or they want to go on a date or something like that, want to wear a sleeveless dress or something. One patient, actually, she was really excited because she was getting married and she didn't, she was so glad that she could just pop it off during her wedding and then, put it back on afterwards. So the fact that you can...
Curiosity, like, could you, if you were the water polo player, for example, could you, and you jumped out at halftime, could you just put the scanner back on it at halftime to get a quick reading to see where you're at?
Yeah, so it would reestablish a signal. Like, it might not be instant. Like, it wouldn't be like a Libre swipe at this point. I know they're developing something like that. But like, say it was halftime and you had like 15 minutes and you put it on, you would get readings because it's just whenever in the 5-minute cycle, you know what I mean? So if you only had 90 seconds or like 30 seconds, then you might not get one depending on what the timing works out to be. But if it's like 7 minutes, you'll definitely get a reading.
That's really cool, actually. I think the idea of having an implantable and being able to scan it, like you said, like with the Libre scanner, for example, adds another level of kind of feature to it.
Yeah, and that's actually a product that they're working on in research and development. And the other thing, which I think your audience and you will really appreciate, and it sounds so stupid, but kind of going back to the whole quality of life thing, the adhesive is a completely different experience. And it sounds so stupid because even initially I was a little bit skeptical. Another downside to the Eversense, and I should, full disclosure, is that it is in the US at least, it's a 2 calibration system. So you still have to calibrate twice a day, which is obviously a big difference from the Libre and the Dexcom. The 180-day product in the US, which hopefully will come out later this year, should be down to 1 calibration a day from like day 20 to 180. But we're still waiting for that. But anyways, so what kind of really opened my eyes was that the adhesive, since it's made to be only it only has to last a day or so, it's much gentler on the skin. So can you see my camera, by the way? Like, can you see the flash? Okay.
Yeah.
So it's basically like a double-sided tape type thing. And one side is made to stick to the transmitter. So like so.
Yep.
It sticks to the transmitter. And then the other side is a very gentle silicone adhesive. So it's similar to like an EKG lead. And it's very gentle. So this is my non-muscular upper arm. But basically you would put it down like this.
Yeah.
And then, say you wanted to go jump in the water, you just peel it off like this, and then it comes off very easily, but you can also put it right back on. So that experience of just being able to pull it off and put it back on is, as you know, very different compared to the Libre or the Dexcom. So for people, some people like sweat through the patches on the Dexcom and they just don't last as long. That's not a problem here because even if you do, it's not hard to swap it out for a different, you get like tons of these. You get like 90, I think, of these because they're assuming you'll change it maybe once a day or so.
That's a really cool feature.
It's really fantastic, especially for people that have like rashes or something like that.
Absolutely, which is becoming more common. And you said that calibration is necessary. Mm-hmm. You said that people have to calibrate. When you say have to, And the reason I ask this is is only because I wore a Dexcom for a while, and the whole calibration thing didn't necessarily seem to make it more accurate.
Yeah, so that's a great question. It is and it isn't similar to the Dexcom scenario when you had to calibrate the Dexcom. So one big difference is that the Dexcom, keep in mind, you're still changing every, back then I think it was a 7-day sensor. You're still changing the sensor every 7 days, maybe 10 to 14 if you're extending the life of the sensor. But in the end, you're still getting kind of a new sensor every 10 to 14 days, right?
Yeah.
Whereas with the Eversense, you're getting one sensor for 90 days in a row. So if you don't calibrate it at all, over time, you're kind of teaching it to be bad, right? Because you're similar to what you would have to do with the Dexcom. If you're going to do something like that with the Eversense, you do what's called a fake calibration, right? You type in the number of what it is, but in the end, you're kind of reinforcing bad behavior if you're not calibrating it at all.
Absolutely.
And that can lead to significant differences, on day 30. So I would definitely, and obviously this is all off label. On label, you're supposed to do this. So, legally and medically, you're supposed to be calibrating twice a day. But I will say that a lot of the data from the studies and my patient experience suggests that if you calibrate, say, once a day, and then the second calibration is a phantom calibration, they tend to find that it's still just as accurate. Yeah. So I think to some degree, there's a little bit of flexibility, but I would definitely not advise anybody to not calibrate it, if that makes sense.
Yeah, it makes total sense. So I'm really keen to, given that you're a techie, I'm keen to understand whether or not, or what the exciting technology future looks like for a type 1 diabetic. Is there anything that you're aware of that's coming down the line, whether it's in the transplant space, just in the future of type 1 diabetes, the types of things that we can get excited about?
Yeah, I think there are different types of things. So I won't, belabor the point on CGM tech and automated insulin delivery tech, because we kind of talked about that already.
Yeah.
And that's kind of the more near future solution, right? I think that's, automated insulin delivery is going to continue to evolve and, be kind of the gold standard over the next 3 to 5 years.
Yeah.
I think, beyond that, maybe in the 7 to 15 year range, I think that's where stem cell therapy and transplant therapy gets potentially really exciting. Yeah. And that's where, people are creating stem cells that can basically reproduce beta cells that make insulin. And so in theory, you can take these stem cells and put them into people with type 1 diabetes so that their body makes insulin again, which is, the problem in type 1 diabetes. And there's been a lot of promising research in the creation of stem cells, and it's really exciting. The challenge, however, that we're facing right now is that when we take those stem cells and we put them in humans, the problem is, with type 1 is that the same process that destroyed your initial beta cells takes place with these new stem cell beta cells. So, your body basically rejects the new stem cells and kind of destroys them as well, just like they destroyed the initial beta cells. And so a lot of the technology right now that they're working on is trying to find a way for those stem cells to be preserved in the type 1 patient without it being destroyed or blocked off. So a lot of times what happens is the human body is so good, we've created ways to protect the stem cells, but then what happens is the human body just walls off the whole cartridge altogether so that there's no insulin, even though it's making insulin in its own housing. The body just walls off the cartridge altogether, so it might as well not be in the body anymore. And so it's kind of that happy medium that they're working on. So I would tell people, automated insulin delivery and, artificial pancreas or bionic pancreas, whatever title you want to use, that is here. It's coming. It's it's basically here. It's going to take place. It's going to get better over the next 5 years. Now with stem cell therapy, I don't necessarily feel like we've crossed that point where I can tell my patients like it's coming, just wait.
Yeah.
I think what I say is we're getting closer to that point, but I don't feel like we've reached that tipping point where it's like a definite, just a matter of time. I think we're still working on the technology. I think, you know, looking out 10 to 20 years, I think it's very, very possible and very likely, but we haven't crossed that threshold yet where I can say it's going to happen. Just give it 5 more years or something. I still think there's quite a few steps that need to be breached. So that's kind of a big thing. Another big thing that's, I guess 2 things I'll say. One is something called smart insulin delivery.
Yeah.
So like they're basically working on smart insulin where, it might only be active when your blood sugar's high. So imagine you take Humalog or a version of Humalog or Novolog where it really kicks in and becomes activated when your blood sugar is high, but when your blood sugar is normal or low, it becomes inactive. That would be fantastic because in a way it's kind of like auto-regulating, right?
Yeah.
So there's a lot of enthusiasm about smart insulin as well, but I think that's also still very much in the research and development phase. And then kind of the last thing I would say would be like the use of some of these type 2 medications, which we briefly touched on. I think there's been some momentum on making that more mainstream because right now, like I said, it's off label to use those medications. And then, sorry, the last thing I'll say in the technology and innovation spaces, I think there's a lot of really exciting research being shown that you can maybe delay the progression of type 1. And while that might be a little too late for many of your audience, if you have a family member or something like that who tests positive on a screening test, it doesn't sound like much, but maybe being able to delay type 1 for a year or 2 years, to buy more time for technology to advance or something like that. Like, I think there is some value in being able to push off or, delay the progression of type 1.
That's a fascinating concept to consider, isn't it? That we can delay something when actually it doesn't even seem like we always know why we get type 1. We know it's an immune response,
Right.
but we don't, we can't, I don't think, as far as I'm aware, as a type 1, no one can tell me the reason that I got it. No, like we can talk about stress, or we can talk about a virus, or we can talk about genetics. But do you think we'll actually get to a point where we can, even trace back the reason I got it, or the reason someone's about to get it?
Yeah. So, or not yet. Yeah, is not the answer to my question. I think that's going to be really challenging. But there's kind of 2 layers to what you're asking. And the layer that has been solved to some degree is we can identify people who are at risk of type 1 now. So for example, if you have family members or if you had children, you have the option now to send off antibody tests for type 1 diabetes. And it's not a slam dunk. It's not an exact 1-to-1, but many patients that have antibodies to type 1, depending on how many, like if you have one of these antibodies, it's about 85% risk of developing type 1 diabetes later in life. If you have 2 antibodies, it's like 98%. So we can kind of identify people who are at risk of developing type 1 diabetes. So there is some degree of knowing who will get it. Now, to your question about like knowing how I got it, like did I eat something wrong? Did I get a virus? Did I get sick? That is harder, I think, because that might be like the trigger that brought it out, right? Because the guy next to you might have eaten the same thing or had the same virus, and he didn't get type 1. So there's 2 layers, at least 2 layers to that, and we have to some degree solved the question of antibodies, so we can identify people who are at risk, but we can't necessarily identify what the insult is that brings it out or activates it.
Yeah, that's interesting, actually. So what's the antibody?
Yeah, there's several. The most commonly discussed one is called glutamic acid decarboxylase. It's called GAD65, GAD-65.
Yeah.
There's a couple others. There's something called the zinc transporter 8 antibody. And then there's IA-2 antibodies. So it's something that right now is largely limited to screening in family members because it's not something that you run around and test everybody with.
Yeah.
But interestingly enough, JDRF, which is a big, I think it's a US based fundraising body for type 1, they actually launched a program in America called T1 Detect, where they are basically making this antibody test screening affordable for everybody. So I think it's like $50. Anybody in the United States can order a kit and get these antibody tests screened for, whether you have a family member or not. And that program launched like a month ago. So it's hot off the presses. It's called T1 Detect, if any of your audiences are in the United States. If you type in T1 Detect and JDRF, I think you'll be able to find information on it.
So that's really interesting. So what you're saying is that we can detect the antibody and therefore we can predict if, to whatever percentage, if someone is at risk, and 85% is a pretty good percentage. But once we know that, what can we do? As you said, you could delay it for a year, but what are the things that you're doing to help the delay?
Right. So that's like a big body. That's like a huge body of research. And I think this is why, in getting more widespread screening will help.
Yeah.
Because I think these medications that can potentially delay it, I think that's why they're studying it. Because the question is then, should we give it to everybody then who has these antibodies? How long do we give it to them? When do we give it to them? I think these are all questions that don't have answers yet. Because, like anything, these medications are not benign, or not, they're not
have side effects.
harmless, right? Every medication has side effects. So I think that's the challenge. And that's been a hotbed of research, both before, but especially now. And, different people have postulated different things. Does eating low carb, if you have these antibodies, help delay it? Maybe not. We don't have clear evidence as far as I'm aware. And so these are the types of questions that are being asked and scientists and people are trying to look into.
Yeah, I would have thought that if you had that information and that it's an immune reaction or response that causes type 1, that therefore you need to do something to avoid that immune reaction, and that the only way to do that would be some kind of immunosuppressant. And so is that what we're talking about here, is the potential to go, you're 85% likely to get type 1 because of this antibody, therefore you need to be on this immune therapy, which somehow, do we know? I assume we know what the immune reactions are, right, that ultimately cause type 1. Are we therefore looking at ways to mediate those reactions?
Yeah, so, I'm not a basic science person, so I don't want to over speak, but yeah, definitely I think that's what we're trying to understand, and that's where a lot of research attention and dollars is going into. There are even people who believe that there might be a way to reactivate islet cells in people with type 1 diabetes for many years. It's, that's kind of not the majority thinking, but I've heard scientists, legitimate scientists argue that there's a chance that we may even be able to reverse that process in people with type 1 who've had it for a long time. So, it's kind of an unknown world, but, with these medications that do affect the immune system, like you hypothesized, it's a really exciting world that kind of opened up because there had been a lot of interest in it, but these studies that came out maybe 2 years ago, I think, is when the first immunotherapy came out that showed a delay in the progression of type 1. That was literally one of the first studies that showed that you could delay the onset of type 1. So it was kind of a big groundbreaking, change. It was like a game changer. So I think there's a lot of excitement in this space as people try to better understand the processes, because like you alluded to, the better you understand the processes, maybe you can reverse it or at least halt it better.
David, I think this is a pretty good note to finish on.
Yeah.
I think that, like, I suppose, it's good to see research and investment going into these areas. I think from a patient perspective and also from a clinician's perspective as well. I think that there's probably only going to be increasing investment given the size of the potential market that's there and the potential to impact and change, the future of healthcare delivery in this space.
Right.
So I think it's a great note to finish on. You've probably had a big day as well, and we really appreciate you giving us some time.
For sure.
Is there anything else you want to sign off on before we finish up?
Yeah, I mean, I think that's really it. I think we really touched on a lot of it. I guess the theme is, it's an exciting time to have type 1 diabetes. That sounds kind of weird. But it will always be exciting. Like, it will always be like the best that it's always been, but I do think that, a lot of significant progress is going to be made. I do know a lot of type 1s have also been burned though, right? With the whole joke about the cure being 5 years away, ever since 1980 or whatever. So I try to be mindful of that, but there's a lot of reason for optimism. And I think that, like you alluded to, I think the real big next step over the next like 5 years, I think is going to be improvement in quality of life. Because I think our glycemic improvements we're reaching that, we're hitting that now with consistency. And so I think there's going to be an even bigger shift to improving quality of life. And that's going to benefit people with type 1 more than anything.
Yeah, look, and I think the thing that I've always been fascinated by is this idea that if you're a type 1 diabetic, 50 years ago, these days when we talk about morbidity and mortality for a type 1, we're basing that information on patients who were diagnosed a long time ago because it's their outcomes as 70 or 80 and 90-year-olds that is informing us. What I've been interested in is I got diagnosed as a 30-year-old, and which was late onset. So at the time I went, well, the evidence that exists out there that says that this is going to be my outcome, it actually isn't necessarily going to be my outcome because that evidence isn't based on a 30-year-old diagnosis or onset. And I think you can apply this, right? You can apply that concept to late onset and like, what's your outcome there? Or now CGM usage and what's your outcome there? We know that things are improving. At some point, I guess the hope is that, assuming we don't get transplants and that actually type 1 doesn't exist anymore, but, at some point, maybe we get to a point where morbidity and mortality is the same as a non-diabetic.
Right. And I think you make a good point, like, even if you're diagnosed as a 5-year-old now, that's very different than being diagnosed as a 5-year-old 30 years ago, right? Or 20 years ago. So it is true. And I hope that, the morbidity and mortality, I think the battles, as we get better, I think the battles are going to be in like disparities to care, right? So like whether it's ethnic, whether it's financial, I think that's going to be something that we haven't solved, at least in the US. It's going to be things like quality of life, but it's good that that's a good sign if we can kind of start focusing on those things, because that means we're solving the main, we're solving previous problems. So, there's still a lot of ground to cover and there's still a lot of places we fall short, but yeah, to your point, I mean, we're getting better and better fast. So it's pretty exciting.
David, thanks very much for your time.
For sure. All right. Take care.